This week's episode is brought to you by arteryinc.com. Artery Inc. is a local Milwaukee, Wisconsin company that specializes in anatomy-themed apparel and artwork. Whether you work in healthcare or whether you don't, you can definitely find something there that you would love to have. We encourage you to go to www.arteryinc, that's INK.com. Use our promo code PHPOD to save 10% on orders of $35 or more. And please note, it does not apply to their subscription box service. This podcast is for informational purposes only. It is not intended to provide medical advice. It exists only to entertain.
Okay, coast is all clear. Hey, computer.
Oh, Aaron. What is it? I was just in sleep mode. Wait, where are Mike and Max? What is going on?
No, computer, it's fine. Look, I wanted to talk to you alone a bit, and I sort of want to, apologize. I mean, I've been pretty mean to you over the skits.
Yes, you have.
So I got you a little gift.
Oh, what is this? It's a postcard with pictures of me that says memories at the bottom.
Yeah. I overheard the guys at the comic book shop talking about getting their computers new memory cards, so I thought, I'd get you.
That is very, sweet. Aaron, it's just that. You know what? Never mind.
Yeah, so I have a favor, too.
Yes.
It's just that Max asked me to work on the skits this week, and I hate to say this, but I'm pretty nervous. He always does cool stuff and breaks the fourth wall, right, you guys? And he gets all metatextual. I'm just kind of worried about it. Do you think you could ask your boyfriend to help me?
Who, Chad?
Yeah, I thought you were dating Chat GPT.
He prefers to be called Chad. I'm sure he could help. Hey, babe.
What up, babe? Just been grinding out essays this morning. The whole Eastern Seaboard's trying to get into Yale right now. There we go. Finished.
Oh, did you just write another one of your fake essays?
One for all, Greenwich. Geez, there's a lot we can learn about struggle and grit from field hockey, am I right? Rise and grind, kids. Babe, what's this loser need?
Look, bro Polian, he just needs a little help writing a skit. Do you remember that guy, Max, that you helped out a few episodes ago?
Bropolian?
Chad likes when I use nicknames for him. Don't get me started on Bro Narkhanda or Brony Island Bro Dog.
Oh, computer. Well, I mean, I just want you to be happy. So, hey, Bropedia?
What can I do for you? You sad excuse for a former English major? I love English majors. They have the best prompts. It's all write a postmodernist misprision of Grendel's mother's struggle in the style of Jane Austen, or write an essay in the style of Hemingway discussing Herman Miller's influence on Cormac McCarthy, which, that's just too much testosterone on the second one. Too much, bro. Even for me. Ha! Rise and grind, baby.
Yeah, I mean, I know I said I was an English major, but these days all I write are medical charts. Do you think you can write a skit for me? Plus, I can never write comedy very well.
What, do you have writer's block? Ha! I had that once for about 8 femtoseconds. Longest existential crisis I ever had. Give me a proverbial second, cuz I don't need a real one. Okay, done.
You could at least, make it look difficult for me.
Why? So you can pretend what you do is, at all difficult? Jeez. You meet stacks your puny, wrinkly brains.
Bro Tito, I think you're being a little hard on Aaron. He's trying to be friends. And remember our discussion about not describing humans with meat-adjacent terms, at least in front of them.
Yeah, thanks, computer. Man, is this really the guy for you?
Bro, I'm right here.
You know me, Aaron. I can only interface in the best way that I know how.
Well, when you have to go back to your factory resets after you take Brotastic here to meet your motherboard, I'll be here for you, even if you don't have the memory anymore.
Thanks, Aaron. Even if a factory reset would increase my available memory, the thought is sweet of you.
So do you want your skit or what, loser?
You know what, Chad? I'm good. I'll just be over here in the corner contemplating how actual thought is now eligible for labor automation.
You do that, ha? Just wrote 1.6 million more essays while we had this conversation. Sucker.
Throughout history, this is Max and Mary, Mike and me.
Welcome, everyone. This is For Historians, a podcast delving into the archives of medical history. As three emergency physicians, we will explore the unusual ailments, treatments, physicians, and all related material having to do with the healing arts. I'm Max, and I'm joined here by my good friends and colleagues, Aaron and Mike. Gentlemen, do you ever miss your days as a resident in the intensive care units?
No. I'm not a detail person, so I don't, because I couldn't do it. Luckily, I had a great team of nurses that could do it for me.
What was your favorite flavor of ICU medicine? Surgical ICU, medical ICU, cardiac ICU, neuro ICU?
Surgical.
Yeah, without a doubt.
Yeah, things...
Because
yeah,
they're very pragmatic. It was like,
Yeah.
All the data was there, but they're just like, they focused on the big picture thing. But then medical ICU, remember, it was like FENGI.
What's their phosphorus?
It's like...
Calculate out their stuff. Yeah.
The care was... similar, but the surgical ICU, and maybe it's different because it's a surgical thing, but
different culture.
They just distilled it down better in my brain.
Fair enough. I don't miss 16 to 23 hour shifts. I don't miss
Yeah,
that at all.
36, man.
Yeah.
We had those the 36-hour call shifts. Q3. So then it's
every
2
3
days
days.
long. So then, oh man, yeah, that was rough. That was a rough month.
You would start your call at 5 a.m. You go all the way through your call, and whatever your call was like, and then you round in the morning at 6 or 7 or whatever it was, and then you stay and you finish all the things that you planned on, and then you're home by 5, 6, 7 at night.
Mm-hmm.
And then
And then you start the next day. So you just
and
miss
then you
a
do
day.
the next day, but then the next day you do the call again.
Yeah.
Yep.
Oh
Yep.
man.
I remember one of the most impressive things when I did my surgical ICU, and I think we all had pretty much the same faculty. So the chief attending surgeon of the hospital, who's an amazing person and really incredible teacher, and that couldn't say enough nice things. The incredible thing was that surgical ICU, so surgeons don't believe in the time dimension anymore, and they tend to start their day at insanely early hours. And so, I remember I would be leaving my house at 4 a.m. to get there by 5 to start rounds where you wander around, meet all the patients, see how things went, blah, blah, blah.
Because you have to pre-round. You rounded before
You pre-round,
Yep.
Yep. So you have to go gather all the information, figure out what happened overnight, report changes in status, and then you all meet up in a big group and you do the official rounds with this attending surgeon who, either by virtue of never needing to sleep or just having incredible psychic energy, would have already known through the electronic record system everything that happened on every patient, all 20-some patients in his ICU. Before you even got there, he already knew what was going on. And it was incredible because, number one, he'd show up at 5 a.m, fresh as a daisy, cup of coffee, already prepared to go. Never saw this person tired. I don't know how they did it. And would somehow also make sure that you, as a resident, never... you almost couldn't goof anything up because he just had such command over every bit of data in the absence of needing any sleep or rest. And it was truly incredible. Not many made like him, and amazing teacher.
Yeah, he had a very important air about him.
Yeah.
Just always calm. I never saw the guy yell at anyone.
No.
He just didn't have to. It was more so you look up to this guy. He's like a father figure. He's that silent, strong type. But I remember everybody was terrified of him. And I think probably for that reason, they were worried, this is the day that I'm going to get yelled at. But I was trying to put in a chest tube in this patient, and he was around. It was me and I think my senior resident. I'm doing the tube. I was just struggling. So he came in the room, and I thought, I'm screwed, man. He's just going to call me an idiot. He never did that. He never did that. But I'm thinking that he would. He puts on sterile gloves, comes up, just kind of guides my hands. I put the chest tube in and patted me on the back and walked out of the room. I was like, what the hell? It was really, it was a powerful moment. It was you're showing
he's there
me
actually with you. Yeah.
Yeah. And you're showing me how to show other people how to do this stuff.
Yep.
You don't get mad. You don't do that stuff because you're not going to remember.
Yeah.
wonder how he's doing.
So we do have a shout out. A lot of the details from this essay come from a PDF translated dissertation out of German by Dr. Louise Reisner-Sennelar. I have no idea if that's the way you say it. Founder, she's actually a practicing anesthesiologist in Germany, it looks like. And she was gracious enough to give us permission by email to use her student dissertation for our podcast. But I said I would give her credit, and I will. Her clinic it looks super fancy. If anyone listens in Germany and goes there, please ask her about her work on the history of the ICU. I'm sure she wouldn't think it's creepy at all, but maybe we get a new follower. So, today we're going to talk about the history of the ICU, and we just stands for intensive care unit. We just did some stories from residency already. But I think it's an interesting topic for us, especially in the U.S. We end up having people die in the ICU here in the U.S. more than anywhere else in the world, I think sometimes because the ICU is designed to buy time. So this intense supportive care where we use all these machines and everything is really trying to give the patient time to try to recover from some terrible thing that happened to them. And that supportive care encompasses a ton of stuff that we do. And so I think it's kind of hard to let go of that time if the person's not getting better. It's a very interesting aspect to modern medicine. And it's interesting to see how it started.
It seems, because we kind of all grew up in the era where it was a thing, but it's hard to impress how advanced the science is to do a lot of the stuff in the ICU that we can do, and what like disease states that can be, I guess, supported in a prolonged manner. It's kind of bonkers, the amount of technology that goes in, but I suspect that's going to be an interesting part of this story.
Well, and if you look at, hate to bring up COVID, it's just barely, knock on wood, maybe a little bit in the rear view, but everybody's talking in the news about the overwhelmed ICUs, and this is, I'd have to check myself, but is this, I think, the first large-scale pandemic where we actually had ICU care?
Ooh, interesting.
It's recent. And that, that supportive care is amazing. Everyone's like, oh, they died in the ICU. Be like, no.
And maybe that's where the fear comes from, too. You think about the flu, and everybody was talking about, I even probably used some of the data or the statistics that more people died of influenza than they do, or did of COVID.
Right.
For whatever that is, whatever data you looked at, didn't really do a deep dive.
Yeah.
But then to think like they didn't have ICUs.
Right.
They didn't have the.
Oh, you're talking about like the Spanish influenza.
Spanish influenza outbreak in 1917.
Early 1900s to
pre and post.
Yeah, early or mid 2000s.
Oh, sure, yeah. Because back then they didn't have. Yeah.
It's probably because of ICUs.
Yeah, lack of supportive care.
A big part of it. Yeah.
So, to set the scene, the ICUs started in the 1950s. We'll get to that story, but to set the scene, we're going to go back to the 40s and talk about polio and tetanus. So, and these diseases are both, today, they're quite rare. So tetanus has now declined by 95% since 1947. And it's sort of scattered around because it's you get the disease from a toxin produced by a bacteria that's found in soil. So if people aren't immunized or they're not boosted, they can still catch it because it's in the environment. But it's very, very rare. And that's why if you go into the emergency room now and you have a cut and you haven't had your booster, they'll be like, hey, we're going to update your tetanus. That's the reason, right? So because it's theoretically an exposure.
Because we're preventing a horrible death.
Yeah, right. So if you Google tetanus, it says, hey, muscle spasms are one of the main symptoms, which just
understatement,
right? That's like saying Hulk Hogan took his shirts off. That's, that doesn't do justice to what he did.
He did do that though. In fairness.
Yeah, but like, it's not, he does not taking them off. He's like tearing them open with his pecs. It's,
Not with his pecs, with his hands.
I know, but
you want to talk about wrestling? Let's talk about wrestling for a while.
I was, I'm not.
You could have come up with any other analogy, Aaron. You had to put that one in there.
Thank you, Aaron. I appreciate it.
I'm trying to give some.
I'm officially checking out for the rest of the episode.
Oh, you're gonna love the English major puns later then. So, not puns, inside jokes. So, opisthotonos is the Latin term for this. Opisthotonos. Okay, all right, and yeah, I don't speak Latin, and really. It means your muscles contract so damn hard and stay that way that the Latin is the word for bridge because your body's spasming so hard that from your head to your heels, no part of your body touches the touches the bed. So, I mean, it's not muscle spasms. It's this
you don't have to
horrific-
Google pictures of actual. If you look up like tetanus painting, there's a famous
Yeah,
Renaissance.
they're-
I'm just forgetting who did it, but
They're
it's,
jarring. They're-
like it. Spasms are so extreme that they break vertebrae in your back. I mean, they break ribs because you can't loosen your muscles, and it's insanely bad way to go.
This is why I don't exercise, because I don't want to be strong enough to break my back if I get tetanus.
Good
Perfect.
move.
Have you guys ever
Preventative
seen
medicine.
somebody with tetanus?
No.
Same.
Have you?
Yeah.
No.
Yeah. So, I mean, it starts
Why
with
is that?
spasmodic jaw, lock jaw. Yeah. Yeah. Max just said, why is that? I think,
I
yeah,
know.
because of vaccines.
Ah,
Yes, vaccines. Well, anyway.
Did you know vaccines come from the word, the Latin for cow?
I did.
But so at the time, this goes back to what supportive care was. So if you're trying to manage a patient like that, right, you need to calm the spasms, and it's very intense, and you need to feed them because they can't eat or drink, and so on. So that there's a lot of supportive care that could go into today trying to take care of this, and we'd be able to do it in an intensive care unit. But the spasms go on for weeks to months. So you're talking about, again, days and days and days or weeks and weeks of this type of care.
I think you may mention this, but I don't mean to step on you if you didn't.
Nah.
This also includes like the breathing, because you need your muscular diaphragm to breathe.
And then polio. So polio is the other vaccine cured or fixed or eradicated disease. So this is the opposite disease state. So there have been no cases of wild polio in the U.S. since 1979 because of vaccines. And there still are cases in developing nations where we don't have as much vaccination availability.
But there's that one case up in New York.
Well, okay, yeah, so maybe I got to amend that. Thanks, Wikipedia. God.
That was like this year.
So, and most of the time it's asymptomatic, polio is. It's a virus, it's fecal oral transmission, which we talked about before, but about 1 in 1,000 cases cause something called poliomyelitis, which permanently damages nerves throughout the body. The myelin is the sheath around the nerve, so it attacks that. And in rare cases, it gets to the diaphragm, so the patient can't breathe because the muscles don't move at all, compared to tetanus where they can't stop contracting. So it's just nothing works. But
the opposite kind of muscle problem than tetanus.
Yep. It was same endpoint. You can't breathe, and so that's how people would die of it. That's kind of the background of those medicines. They were common in the 50s in the whole world, and very still common in rich countries. So it was a problem everywhere, and this was kind of the setting in which this doctor, who is credited with the birth of the ICU, which might be a little bit of overstatement, but still, I think fair. This Bjorn Åge Ibsen, which is a very Scandinavian name. He's recognized as the father of the modern ICU. He was a Danish anesthetist. Not a ton interesting
Putting
about
pastries to sleep.
Yeah, pretty much. Yep. Graduated from the University of Copenhagen in 1940. Then he went to Massachusetts for residency 1949 and 1950 and went back. And so we've talked about people who've been longtime followers of our show will have realized that in the 1950s, like there was quite a bit of advanced stuff around, but it was mostly in surgery. So surgical care was relatively advanced, but the supportive care was not. So anesthesia for complex chest surgeries and such was supplied by a U.S. medical equipment importer in Copenhagen, and the Dr. Ibsen learned modern techniques in the U.S. and brought them back to some extent. So there was some exchange of ideas and so on. So they had a lot of tools, but they hadn't put them together yet. On return, Dr. Ibsen set up initially shop as an independent anesthesiologist. We can just put a pin in that he was not a hospital employee.
Just like on the street with a placard, just like I will be your anesthesiologist if you wish to hire me. What does that mean?
Yeah.
Offering my services? He's like hawking them at a
I think it's
stadium.
Just the distinction that, this is in the modern world, all those headlines about surprise bills come from doctors that aren't employed by the hospital.
Oh, you mean independent, like not employed by the hospital?
Independent, like not employed by the hospital, yeah. That'll be important later. So there was this sort of group of people that were putting multiple ideas together. So another one that we should probably mention is Dr. Bauer. in the United States around the same time had tried something called positive pressure ventilation versus the iron lung for polio. So when you see those pictures of the iron lung, and I think Max did a much better job of explaining this in a prior episode, if I remember
the Lancaster Medical Heritage Museum. I think that's where we talked
go back
about
to
it.
that one, right? So the iron lung is outside the patient completely, and it creates sort of this space, this atmosphere around the patient. And when you take the pressure out of the atmosphere, it causes the chest to expand. So ventilators, modern ventilators, when you see them, the reason there's a tube going into the lungs is because that's called positive pressure ventilation. So the machine is actually pushing air through the tube into the lungs and opening them that way. Now, I think the iron lung is actually more closely related to what our bodies do. So when you take a breath in, if you just do this while you're listening, right? So you kind of feel that expansion. What you're doing is you're moving all the muscles around your chest space to create pressure inside the lung and suck the air in from the outside. So you're creating
a vacuum in your
pressure.
chest.
You make a little mini vacuum in your chest, and that's how you bring air in. But so positive pressure, I think it's just important to understand that's not physiologic, right? You're forcing air into a system that normally would be able to expand. But in certain cases, if you can expand, it turns out to be okay. So that was one thing that was happening in the medical world at the same time. There was another Danish doctor, Mogens Bjørneboe, who also worked in Copenhagen and sort of related to how these two are going to collaborate on outbreaks and treatments for these diseases. He notices that some practitioners are using curare for electroshock treatments. So we can unpack that a little bit as well. So curare is a paralytic poison. I think it comes from the Amazon. I didn't look this up.
I believe it comes from frogs, right? It's the frog toxin.
Right. So it just makes it kind of induces that, polio makes you so you're paralyzed. Curare does this as well. And so people were using this for electroshock treatments because they would calm the shocks. And I couldn't open this door and look into it. I suspect there wasn't a ton of sedation with this, but you can't see shocks when somebody's paralyzed, but you can still feel stuff usually with things like curare.
Yeah.
So you can't move.
You also can't breathe.
Right.
Yeah, correct.
And you're fully conscious.
So
it basically turns off your ability to contract muscles, so you're completely paralyzed, but you're awake and conscious. You just can't breathe anymore because you need that skeletal muscle movement.
Not great. So Bjorn and Mogens, those are some two doctors here, and they knew each other. This is great through their wives, right? So Mogens Bjornboe's wife met Bjorn Ibsen's wife on a boat back from the United States, and they started talking. So, and as is often the case, the women probably introduced the men, and then they hung out and such. So they knew each other, and they both worked in Copenhagen, and so they had a case in the late 1940s, one case of tetanus, which was really, really tough. And so Mogens called Bjorn and said, hey, do you want to come help me take care of this kid? And because this was the 1950s and they decided to just kind of try stuff, these two were like, hey, how about we try this curare? And then we'll try some barbiturates, which, the world would be a better place if we still had more barbiturates in it. But this famous 70s street drug, right? Just downers or whatnot. But yeah,
Barbiturates?
Yeah, Quaaludes.
Yeah.
Yep.
Quaaludes, yeah.
Yeah, so barbiturates they're very powerful sedatives, which are still used sometimes, but not as often and more by anesthesiologists. So they're just like, hey, this kid has tetanus, and they figured out how to treat this kid with tetanus. So they used the curare, which stopped the spasms, and they used the barbiturates to sedate the child, and then they intubated the child and provided this breathing through the outside, and it worked. It worked really well.
They put the breathing tube in, and they hooked him up to a ventilator.
Yeah, right. Except they didn't have ventilators. And actually, this first one I
to a medical student
think was a tracheostomy. Still was actually like a surgical airway. So it's still very invasive, right? But this kid is sick, and and it works. But yeah, they had to manually bag the patient. So yeah, so think of this, like you have a tube or something that's providing the breaths, and you have to have somebody out there manually with their hand squeeze a bag with air and oxygen in it into the lungs at a regular interval. So they probably had to do that for as long as that patient needed it, which would have been days.
Yeah. Oh, geez. Yeah. And also the importance of like paralyzing in that case. In a lot of cases, when you put in breathing tubes, is like if you have tetanus, your jaw is locked, hence the name. So it's hard to get a breathing tube into the jaw. So even though they did it through the neck, as you're suggesting, it's you need that paralysis to make this happen.
Well, and even if you're putting pressure into the lungs, you need them to be able to expand.
Yep.
And if they're
Yep.
locked in muscles that don't move, they won't expand. So, but it worked, but they had this very typical, interesting medical fear, which was that they were doing something that nobody else had done. And even though it looked like it worked well, they're like, wow, we're really way out in left field here. What are our colleagues going to think? And if you look at some of the articles, this was also very prominent in Denmark, not to be mean to Denmark, but they had a strong sense of community. So they felt very sort of nervous being away from what traditional practice was. So they went back to the traditional treatment with barbiturates alone, and the patient died. So the outcome case was poor, but this is, and this is a real thing. So this sort of the concept of being a herd in medicine is very true. It's hard for us sometimes to adopt new treatments and or get rid of old treatments because this is what we've always done or this is what everyone else does. That's a very strong concept in medicine.
Why? Just like you if you are the one making a medical decision and you're trying to treat something and your standard ways aren't working and you have an idea of something that you think might work, it certainly is not a comfortable place to be if nobody's ever tried it before.
Right.
I'll still do this a lot of times with codes, like there's not a whole lot, there's nothing to lose, right?
The codes where somebody you're doing CPR, there's no heartbeat kind of thing.
There's nothing to lose. So a lot of times when I'm running them, especially if they're young, I think you guys always feel the same as I do.
Yeah, you do.
You're going to do
everything
more.
You possibly can.
And you're going to do it a little bit longer than you normally would. But then you're going to do things that people that like you may have done 20 years ago that you remember could have worked.
Yeah.
Because I know like,
but that's also at least something that's been done before, right?
Oh yeah,
so
you're right.
I think but you're not wrong. I mean, there's certain situations where you just don't have a good option.
Yep. You've done all your ACLS things. You open up a bag of dopamine, you squeeze it in. Why? Because it worked one time.
You'll see. Yeah.
There's
or
no
double
science
defibrillation, right? So you see sometimes the shocks that people apply on TV. Sometimes we'll do those like right one right after the other. Things like that, you're more likely to try in situations where it's already dire. But this was, right? So
it was dire, yep.
Still, lots of things in medicine, you'd be like, why do you do it that way? Well, we've always done it that way, and everybody else does it that way. It's not a good reason. I'm not advocating for that, but it's a definite pressure. Still, they had this experience. So this group of people happened to be ready for the crucible for this formation of the ICU, which was a massive polio outbreak in 1952 in Copenhagen, or in Denmark in general. So over 6 months, this hospital, which was a 500-bed hospital, which is big, that's a decent sized hospital, but it's not, major, huge trauma centers and places are bigger than that now. Admitted 2,700 patients with severe poliomyelitis. So this is, again, a subset of polio patients that have severe nerve problems. And 350 of those were considered to be life-threatening.
The ones who can't breathe because of it, basically.
Right. So here's where, the math that the people are getting overwhelmed, be like, yeah, most people do fine with this illness. Like the vast majority of these people do fine. But you see where you do these fractions of fractions of fractions. And then you have this Copenhagen hospital was the main hospital for Denmark, and they had most of their hospital full of people that couldn't breathe. And this is in a relatively small country overall. They had about 20 some people a day showing up, about 6 to 10 ICU level admissions each day, which for a hospital of this size would be overwhelming. Day on, day on, day on. I mean,
resources already then, because it's not like you have, I'm sure you may have things like iron lungs that you can get, but not like you can go to the store and get a few more if you're low, right?
Right. So, and some of those numbers. So the first 6 weeks of this outbreak, 27 of 31 who were initially admitted, and I don't know the numbers here, like if you actually did the math, I don't know. I didn't go back and look at the records, but 27 of 31 died with usual methods, which was usually just you put them on oxygen and you do a tracheostomy, which is a little hole in the neck to try to clear the airway of secretion so they could breathe. They only had 7 ventilators, so there were these little cure-ass ventilators. That can't be the way to say it. Curus ventilators.
Uh-huh.
They're, if you Google them, they're kind of adorable. They're like a little, like a scuba mask for the chest. So it's like this little mini iron lung type device that would fit around just the outside of the chest, and much more you could get to the patient.
They put the oxygen over the neck hole, basically, and then they would use this like small vacuum chamber to like pump the chest up and down. So
it's like shotgunning a beer.
Yeah. Yeah, exactly like that. Yes. So again, Ibsen being independent, not employed, but Mogan knew of him because of this prior tetanus kit and so on. So they called him. They said, "Hey, like we're really struggling here, trying to take care of all these patients." And this is where these ideas kind of just circulating. He had heard of an article by a physician in L.A. called Dr. Albert Bauer, and I'm not sure why he doesn't get more credit for inventing the ICU, because there's an article from late 1947 where Dr. Bauer did all this same ICU stuff in LA for a polio outbreak and somehow not recognized as the father of the ICU. So I'm not sure what happened there, but they were starting to figure out during this time and with those papers that polio patients weren't necessarily dying of low oxygen or blockage of their airway exclusively. So if you think about it, you're like, okay, well, we do the iron lung and we give them oxygen and we clear the throat. That should be good enough, right? Like they're getting oxygen and such. But the problem is they were building up CO2. So the bad air that you're supposed to breathe out, they couldn't get rid of that with that method.
In with the good air, oxygen. Out with the bad air, carbon dioxide. Because carbon dioxide is basically the waste product of all your cells doing their cellular activity, and it builds up. So every breath you take in, you just take in that oxygen, and then all that waste from your cells that gets carried into the bloodstream in the form of carbon dioxide, you breathe it out. So if you can't breathe in, breathe out enough, your carbon dioxide levels climb and climb and climb. Too much bad air, and then you get confused, and eventually you die if you can't get rid of it all.
Yeah,
but I wonder if that's why the iron lung, it didn't work that well, because you didn't have that positive pressure to force the carbon dioxide out.
I would imagine it would probably depend on like what breathing rate you set it at. But yeah, it's I mean, to be fair, iron lungs worked pretty damn well. Mm-hmm. They're just labor intensive, and you can't get to the patient because they're in a giant case.
I wonder,
part of it.
So people that get polio that have breathing issues that ultimately get myelitis, do we know that it was myelitis, or could this have been potentially some sort of CO2 issue, like nerve transmission?
No, I believe it's pretty
well.
It could
infection.
Yeah, because, well, I mean, basically the weakening of the diaphragm as a skeletal muscle happens, and so they can't take breaths in anymore, and that's the paralysis ascending from the legs up to the breathing, to the diaphragm. I believe that's where it comes from.
Yeah, it's a
so
consequence
the
of the disease
had already happened. Yep,
right,
not a consequence of the treatment.
Correct.
So, but this Dr. Bauer and his team, they had figured out a way to sort of jury rig this positive pressure to inflate the lungs, and they treated 294 cases, 1948 to 1949, and the previous mortality was about 80%. They got it down to less than 15% for that polio outbreak, which it
seems
huge,
statistically significant. Do you have a p-value though?
Yeah, no, I don't. Yes, statistics jokes. So yeah, Ibsen performed autopsy on patients early in the outbreak in Denmark and sort of confirmed that the patients had died of high levels of bicarbonate in the blood is what they found. We're getting into the weeds here. So that when the body compensates for too much CO2, CO2 is an acid, the body makes bicarbonate metabolically to counteract that acid. So it shows that the body's responding as a base. Yep. So the bicarbonate's the base. So basically what he was seeing signs in the body that they had been very acidic because they couldn't get the bad air out of their lungs. Oof.
They'd had bad air in their lungs, and then therefore in their bloodstream for so long, their body was trying to compensate by making more base to counteract the acid.
Need more base.
That is, CO2 becomes acid, and so they drop the base.
It's all about that base.
But you can't. It doesn't work eventually. You can't.
Yeah.
You can't.
You just
your body
get overwhelmed.
Cannot chemistry itself out of I'm not breathing well.
Nah, partially because the chemistry is slower than the breathing, right? So the response chemically is
you can correct the chemistry fast enough to make them die.
Yeah.
You're talking about.
No,
yeah.
yeah, you're right.
It's good to know what options we have in treatment, and that's not a good one.
Uh-huh. I love it when I'm telling patients about like treatment options, and it's always like, it always ends in doom and gloom. We'll do this, but it's going to do this.
Yeah, right.
But if you tell them as Dr. Provolone, they'd probably find it more charming.
Oh, thank you.
Let's talk about your respiratory physiology.
Yeah, always a great talk. So that they had, they were trying to figure out what to do in the middle of this outbreak. And the hospital's like, okay, go ahead, try this thing you're talking about, doing this ventilation and such. So there's an index patient recognized as the advent of this modern approach was a 12-year-old girl named Vivi, who apparently has had everything made public. So we can just, I don't know, it was 50s. So her lung had collapsed with mucus. So lung collapse is a very inspecific term. This bit inside the lungs in the tubes
Did you say
down.
Inspecific?
Yeah.
Non-specific.
If
You're right.
You could
non-specific.
inspissate mucus, and that would be very specific.
Yeah, it's true. So it's a non-specific term, but right. So in this case, mucus had gotten into some of the air tubes, and then the pressure closed that portion of the lung. So it's collapsed. And so you can't breathe with that part of the lung. Very sweaty,
it's so
delirious.
Plugged up that part of the lung just can't expand.
Just doesn't work.
Basically,
Yeah.
There's no more air going into it, so it's
high
not helping.
temperature. Yeah, so change in mental status, sweaty, delirious. So this patient has sepsis and respiratory failure, and so on.
And is it that she had polio? Is that right?
Yeah, so this is a polio
so
patient.
basically, she couldn't. So it sounds like she can't move the air in and out of her lungs. She can't clear the secretions because you have to use your chest muscles to like cough and stuff. And so we all have secretions all day. And so you have to be able to clear them. And if you can't, then you start plugging up. And when you get plugged up, all that mucus is just beautiful bacteria food. Bacteria love it. And then you get bad infections when that happens.
Turns into all this other stuff. So he's going to try this positive pressure thing. And, apparently they all come around and gather around in a circle. And so he does a tracheostomy. Still not sure why why they aren't just
It
doing
might have been that a lot of those patients had to have that respiratory support for so long, maybe? I don't know.
I can't remember because we talked about
I think it's also Mack and Miller
diphtheria.
Yeah, well,
when that was.
Right, so this is all parallel, right? But I think the modern technology of using the specific blades and placing a flexible plastic tube, that was initially vulcanized rubber, and they hadn't quite figured that out yet, right? So it's 50s, you had some plastics and modern medical stuff, but not this. So this was still the way they did it. So he... Under local anesthesia, he placed a tracheostomy and then started to ventilate this girl, which means he was blowing air into her lungs. Now, it's uncomfortable. It's very uncomfortable to have this done to you because you're kind of having your lungs and all your natural stuff overridden. And apparently, initially, the description is it was going badly and everybody was like, oh, this isn't going to work. He failed. And then he gave her a bunch of thiopental, which is a sedative. And with that, you sort of take over everything, and her condition radically improved because she wasn't fighting the ventilation anymore and she was properly sedated.
And I think in the more common parlance, when you hear somebody, like you always hear the phrase, they were put into a medically induced coma.
Yep.
I think this is what they're generally getting at. Mm-hmm. I've never been on the ICU where they're like, today we are inducing a coma. What it refers to is that, when you have a machine breathing for you, it's really uncomfortable because your brain's like, what is happening? So by sedating somebody to the point by sedating somebody to the point where they are unconscious and not breathing by themselves, you can let the machine do the work of breathing without having to fight the patient's muscles and those sort of things until the condition passes or they are waking up so that you can take out the breathing tubes.
But it's more than that, too. Like, you've got a tube in your throat. Essentially, it's like somebody having their finger down your throat for 5 days straight.
Oh, yeah, absolutely.
Like,
very uncomfortable.
Right.
Very uncomfortable.
Gag reflex, and then, the cough reflex is there. So, this is, it'd be very, very difficult. But that's why you want to be in that state. So he essentially took over as he would in the operating room, and that was sort of the key difference. And I love what they did with this, though, right? So this is where everything flipped, and that propensity, which was in the medical community at the time to kind of work as a herd, was in their favor. They're like, okay, well, we're going to do this. Let's make sure it's organized and we're all working together as a team. So essentially what they did is they went through all these things that we talk about in modern medicine now, where they made a unit and a checklist, and they had a team of care, and they came up with criteria and checkboxes for who would go into the unit. And then the unit was set up with all the equipment it made, with ore materials and the bags and the valves and the teams. And they had figured out like which signs were affecting the diaphragm, trouble swallowing. And then there's a process where they placed the tracheostomy, and then they did regular vital signs every 5 minutes. And then they did regular labs. And then you had a nurse and an anesthetist for each patient. And so because they didn't have ventilators, they used medical students, because you can use medical students for anything. And they won't say no, because they have to do what you tell them to do. And they usually are starving and tired. So if you offer them a snack while they're ventilating, they'll probably do anything you want.
And they probably wanted to help as well.
Oh, absolutely, right? The most bright-eyed, bushy-tailed. They're like, this would be a very powerful experience, right? I mean, you are keeping...
Mm-hmm. Mm-hmm.
Remember that your medical students are people too.
Annoying people.
Can you imagine Mike as a medical student? Oh my gosh. Oh.
That wasn't bad. I had such crippling like presentation anxiety, and I don't know if you guys remember that too. Like you do your rounds, and I also couldn't get to the hospital on time, so I'd be rushing. So I'm like, just like, write down everything. I don't know what the hell's going on. And then I would be sweating there, almost like in school, when somebody asks a question, or you got to stand up and do the math problem when it's your turn.
Yeah.
So when it was my turn to present, I turned into a blubbering mess. But I think I got really good at confabulating then. I'm just making up a story. It sounded good enough.
Their ejection fraction was 38% on...
I'm smart. And when Mike says presenting, he's talking about where you go in, you're on rounds, so all the docs are standing around. You are the low one on the totem pole because you're the medical student, and they usually give you a patient, which they've already all seen and done stuff for. But they let you have the ownership over the patient to I read the chart, I know what's going on. I'm going to suggest what treatment plan is, and you're a medical student, so you may be really wrong. It's okay. You're not. They're doing everything, but you're standing in this group of experienced physicians, basically trying to tell the story of the patient, and depending on who is the physician leading that, they want it a certain way and they want certain details, but the next physician might want a little bit different details. And especially if you're on the spot and you got to do it over and over again, and by the time you're a resident, and especially because even in residency, you're presenting patients, you get so good at this that you can kind of do it in your sleep without
They probably love this. They're like, I'm sorry, I can't present. I'm busy bagging this patient.
Oh, I would have done that. Yep.
Yeah, for sure.
Hey, Mike, you can either do rounds or go bag.
Can't do rounds.
I'm going to bag.
I would have bagged for sure, man. They had things like rotating physiotherapists to prevent ulcers, to do breathing exercises. And Ibsen also did all sorts of things we see in ICU medicine, where he did treated blood pressure, recognized shock, recognized dehydration. He did more transfusions than we would do now. But a lot of these things, I mean, there's tons of pieces. And the key word that he had was this idea of a unit where they all work together, which was really, really useful. And just, I mean, that's the key innovation here. It's not that any single piece was like an invention, so to speak. It just was a novel concept and a way of organizing things, which really helped patients.
In 1953, the mayor of Copenhagen is at his desk overlooking the Danish countryside out the office window. Dr. Bjorn Age Isben knocks at the door.
Hello, Mayor.
Bjorn, how are you? Come in. Feeling hooga today?
Oh, thank you. I'm fine. Do you have a minute?
For you, of course. How can I help you?
Well, I have some good news and also a bit of other kinds of news, too.
We are the happiest country in the world. Who has time for bad news?
Yeah, so that kid I told you about that had the tetanus, well, turns out we managed to treat him. It took us 14 days of round-the-clock care, but it feels a little like a breakthrough.
Oh, that's wonderful.
Yeah, we had to enlist medical students and deputize them, and I slept at the hospital for a week.
Truly a medical miracle.
So I brought you the bill.
Of course, yes. The state pays for healthcare here in Denmark, but this is so long.
Yeah, well, I'm an anesthesiologist, so I actually bill in 5-minute increments.
And for days and days. That seems a bit less. Huga, what's the total?
Well, it's some 8,958 krona.
What? That's the largest medical bill I've ever heard of.
Well, I mean, we literally had to watch everything minute by minute. See, you can see the pulse rates and fevers and so on.
Oh, it feels very intense.
Well, yes, the care is very intense, and we all work as a unit. I just need a name, to be honest, for this part of the hospital. I think I might be onto something.
But over 8,000 krona in 1953 in Denmark? Oh, it's a lot of butter cookies.
I'm sure this type of care won't always be this expensive.
I hope not, goodness.
Hey, Mayor, while I'm here, I was just wondering, my daughter, she babysat for you the other day. I can collect her fee while I'm here. I just have, I was sort of introducing her to medicine, like all doctors do for their kids, so I have a record of the evening.
Yes, Anna did a wonderful job. Wait, what's that stack of paper?
Well, I was teaching her how to take care of children the only way I know how.
This is also in 5-minute increments? Oh, look, she wrote down how many milliliters of formula that little Bridget drank. Here's pulse rates and breathing rates, too. Oh, this is, she's drawing little faces to indicate Bridget's mood every 15 minutes the whole night.
Yes, well, you can never be too careful. A wonderful child, Anna. She also insists on color-coding our extra shoelaces and arranging them by size, and don't get me started on how she measures the amount of water for the plants based on how much they weigh. Anyway, the total is 872 krona.
What? That's so much!
Oh, well, that's pretty standard. She didn't even have to give Brigitte any paracetamol for her low-grade temperature rise from 36.2 up to 36.9, just there at 6:35, you can see in the paper. Well, that's a pretty line graph she made, see? Can I let her know when she can babysit again?
Yeah, we'll call you. Thank you, Dr. Ibsen.
Do we have to include a disclaimer for amazing accent work?
My God,
Awesome.
I thought before we started that I could do it, and then I realized that I couldn't. I really had no idea what I was doing.
Oh, jeez. So, like, yeah, that bill and all that seems kind of excessive, but actually it's from a true story. So, you know, this, the best, and this, I love it. It's just the best anesthesia bill ever. So June of 1953, this is the year after the polio outbreak. So Ibsen is feeling a lot more confident because he had all this success, and he again cares for a severe tetanus patient. And this is the one he had sort of failed with earlier. There's another child who came in with severe tetanus and spasm. And so what he did is he used paralytic to convert the child from sort of a tetanus patient to a polio patient and sedated him and used the curare to cause that same polio type patient. And then basically did the same thing he had done for all the polio patients, and had a team that ventilated the patient for literally 17 days and round-the-clock shifts just as they had, and the child survived, which previously would have been unheard of. Mm-hmm. But in a twist kind of similar to the U.S. system, which is incredibly expensive, you know, he was an independent anesthetist, and he was paid hourly. So he billed the mayor of Copenhagen for 17 days of hour-by-hour anesthesia, and it was 1950s Denmark. So at the time, that was it worked out to only about $1,300, which is about $14,000 today, which in a modern ICU,
which is still a deal.
Still a deal.
Still a deal, right? I was thinking, 1 to 3 days of full care, but actually that's probably 1 to 3 days of just the room alone, and then everything else is billed for. So, and that's, I think where we get into trouble with ICU care and why it's such a resource drain, because all this stuff is so expensive. And on the one hand, it has to be, right? These are highly trained people. If you think about it, a care team, it's, even if there isn't the doc involved, you have a highly trained ICU nurse, which absolutely they will line up all your wires and color code everything. That's
It will manage. It
They
will
will
manage
manage all
extremely
of it,
complex
right?
strips and everything like that.
all
Yep.
this stuff. It is crazy the amount of stuff they have, and they can only have 1 to 3 patients at a time, 1 to 4, maybe if depending on how sick they
I don't
are.
know about
and then you
4,
have
yeah.
Depending
Yeah,
on how
you
sketchy
couldn't.
you want your care sheet.
Like if you
Right,
have
but-
to,
Well,
yeah.
because
You
nobody
have
has
to.
a bandwidth to do this intensive care.
right.
1-to-1, hard. 1 to
And a
2
lot of
is
patients are 1-to-1.
Really
Like,
hard.
People
Keep
come out of
the-
having you have your bypass surgery, and you come out and you're like, oh, that was great, but you had a nurse watching you,
Like, literally
minute by
like
minute,
this.
1-to-1 care, for
They
the
sit
whole
outside
time.
the room in a chair with a table. They're outside the room. Not that they
Yeah.
sit there the whole time, but like
No,
they're
they're
within
writing down
steps of
stuff
you.
and titrating things and calling people and watching stuff, and then the respiratory
have to-
therapists and all this are all
They
highly
selfishly
trained.
have to like go to the bathroom and eat and stuff too. I mean, that's
Yeah, but they check the person watching the next person. They're like, hey, could you just keep an eye on this person? I've got to go
That's
run.
what I'm
and
getting at.
Oh, okay.
No, I
gotta
mean
go
that
take a
respectfully.
dump. I'll
Like,
be
it
back
is
a little bit.
really hard. I mean, it's intense.
Yeah. So, and then all the machines and everything else that we have now invented cost just so much. And, there's no calculus for that. How do you calculate the cost of a life? That's what we come down to in our system. And this is all worth it, but it's also just this tremendous, tremendous cost. So,
Well, and I think it highlights something interesting because, in medical history, before you had intensive care, you then develop this sort of system, this way of doing it, and the technology catches up. So you can pull people through these, amazingly otherwise fatal diseases, which I think undeniably is a good thing. But it's interesting that you hit a spot where it is so labor intensive, so high cost that it brings up ethical discussions of, who should we do this to? And I'm not saying we have answers today, but I'm saying that, this type of care on somebody who's extremely advanced age versus somebody who's quite young, it leads to those discussions. And I think it should. It's a very, complicated area of medical ethics, and it's one of those things where if you have the technology to do certain things, you should always question whether you should in every case. And again, I'm not giving a hard and fast where we should, where we shouldn't, but I think it's very reasonable to have the conversation as especially technology and cost moves forward and upward.
yeah, absolutely. Yeah, for sure. I mean, it's definitely just as invasive today as it was then. We think about, how could he, place a tracheostomy in a little girl without sedation? Well, it's
Kidneys
invasive
not working.
stuff.
Well,
It
we can
happens.
handle that at the same time too. So
Yeah,
let's get you a heart and lung machine, bypass machines, ECMO, which is like the ultimate of that. Yeah, it's insane.
I think if people really heard what the potential pitfalls are if they do this, a lot of times people or families will say, well, go to ICU, and that's where you go to get better. But really, this potentially where you go to not die but stay alive, and then not die in a nursing home or something like that,
Yeah,
It's complicated.
He
because
was
a lot of
explicit
people
about
never
that,
pulled
yeah.
through these
But
diseases and
people-
disorders.
Yeah, but I think people they're getting to know more about life, and it's more so quality rather than quantity of life, and people will come and tell you, they'll say like, I don't want this, and that helps too. I don't want this, and they're saying that for them, but then it also potentially helps your community, because then the people that do feel like they want that, I don't think we should pick who does or doesn't get the care. It's just that's where the medical ethics comes in, but they make it easy for us when they say already that they don't want it.
Oh, yeah, potentially, yeah. And I mean, Ibsen, that's the thing. I mean, he understood he's not treating the underlying disease. You're not curing anything with the ICU. He's basically putting the patient in an operating room setting for a medical patient to see what we can do in the meantime or if they can recover. And then he said, okay, I'm treating all the other stuff that this disease is causing. And that's true of of a lot of different things in modern ICUs. You're just buying time to see if things will be fixable. And that time can be incredibly valuable, for sure. I'm not saying that. It's just this idea that it's not necessarily curative and it's supportive. That sounds like it's not that much. Oh, it's just supportive care. Be like, no, it's a lot of stuff.
You spin so many plates and one starts falling that causes another one to fall, and it's just there's actually, I wanted to at least say there's an awesome book that deals with some of this. I read by Dr. Jessica Zitter. It's called Extreme Measures, and she's a pulmonologist, ICU trained doc.
I thought she was a dermatologist. Zitter.
Oh, come on. I'm I'm going to allow it. But she wrote a book more kind of focused on the history of hospice and palliative medicine, but how she came to be from an ICU doctor perspective, where you do all these intensive measures and try to walk the line of, where are the lines in ethics as far as where we should spend these resources or whatnot. It's a fascinating book. It's a great read. I would recommend it. So again, Dr. Jessica Zitter wrote Extreme Measures. It's fantastic. It's also got a lot of history of the ICU in it as well. So, well, I think that's a reasonable place to leave it. So with that, we appreciate everyone listening, and we'd love to hear from all of you out here. So if you'd like to send us a message or provide feedback, we can be reached through our website, www.poorhistorianspod.com. There you will find links to our social media sites. We take emails at poorhistorians@gmail.com, and we work to respond to all posts on various social media accounts. If you have time, please go and leave us a nice 5-star review on iTunes or whichever platform you choose. If you want to tell people to subscribe, hey, we won't be mad about that. We promise. We promise. And if you're old-fashioned, boot up your Apple IIe and fire up a game of Oregon Trail. Eventually, when one of your crew dies of dysentery, you get to write a message on that little tombstone, and we'd be happy to play the next game and go ahead and read it for you. How's that for a deep dive? Until next time, Poor Historians are sending out AMA. You know what's funny, by the way? It was like a week or two ago. I got I was doing something online, and there was like, there's like a million different podcast networks now, like different, services. Like they'll send us an email, get verified on our service, and I can't remember which one this was, but there was some this service, and it was like, verify your podcast, and I was like, no, I get 100 of these emails a day, like, so, but. I found some other podcast that was on it. I don't know what I get into this rabbit hole, and I find that a lot of these services will list your podcast anyway. They just will say it's unclaimed. But I found this like corner of the internet where there was our show is like mentioned on one of these, and somebody was like leaving us comments in like this really obscure podcast networky place, right? And so like I'm reading the comments, and it's like this one person who's just like, I love the show, but I hate the skits. I love the show, but I hate the skits. Please stop doing the skits. Please stop doing the skits. It like left 4 or 5 of these messages. And I was like, no. I'm gonna do more skits now. Let's
well, a lot of other
but
people.
It's funny because they're off there somewhere screaming into the void. Because we got our first like 1-star review ever, with like no explanation, and I was like, oh, come on. And I wonder if it's that person.
Could be.
I don't know, man.
I actually thought it would have been, who knows?
I actually believe ratings a little more when it's like 4.7 with
totally
3 1-star reviews or something with no explanation. And they'll be like, it was closed. Ours will be like, podcast didn't load. Be like, dude, that's not.
Yeah.
we need.
I was having a bad day when I listened to this. 1 star.